Today we have four, let's say, presenters. First one will be for thoracic aorta, Maciej Smigin from Poland, and Antonio will talk about the case. He is from Zagreb. After that, we'll hear something about interventions on abdominal aorta from Katarina Klausenitz from Vienna and her colleague Fredrik Marek.
So I would like to begin with thoracic aorta aneurysm. They are called silent killers because vast majority of them are asymptomatic. Most common risk factors include male gender, of course, hypertension, COPD, and coronary artery disease, and smoking. And of course, there are some genetic conditions that increase the risk of having thoracic aorta aneurysms. And these are quite rare, but still Marfan syndrome, Ehlers-Danlos syndrome, and so on.
So immediately after the patient arrived at our institution, we translated into our angio suite. We placed a pictal catheter via the left subclavian, as you can see here, with the tip in the ascending aorta, and a stiff guide wire via the right femoral approach, as you can see here, also ending in the ascending aorta. Then we did a series of digital subtraction angiographies, where you can clearly see the ascending aorta, the arch of the aorta, the descending thoracic aorta, and our pseudoaneurysm, nicely visible here as seen on the CT scan.
We have plenty of pathologies, but most of them can treat it with the same thing as a stent graft. Some pathologies, we don't even need a graft. Maybe a stent might be enough. And in some rare cases, we can also think about fenestration in complicated type B dissections where we have no re-entry and want to make a new entry so that the true lumen can be perfused right more.
So we got a CT with only a venous phase, but what we can clearly see is here a large retroperitoneal hematoma. What we also can see is that there is no large amounts of contrast inside of the hematoma. So maybe we have had a bleeding and the bleeding is not in acute setting right now.